Move on now and talk about new models of care to reduce TB mortality and to improve outcomes. So Greg and then Angela Kelly will present us.
Thanks very much, everybody. It's wonderful to see everybody who's here in person, and hello to people who are online, and I hope that we can have an even bigger meeting next year when we can get international visitors coming to Australia as well. So I'm going to talk today about a couple of projects relating to digital health. So the context is that in Vietnam and around the world, if I can, that at the moment, one of the big challenges in controlling TB is that we have only about an 85% success rate for our treatment. So you can see here a figure from the most recent global TB report that shows that there are still about 15% of people who have gone through the entire cascade. They've been diagnosed, they've commenced on treatment, they have active TB, but then 15% don't successfully complete treatment. And this represents an important challenge from a public health perspective. You can see here that this is a problem in many parts of the world, but particularly in Southeast Asia, in the bottom right corner there. And given the number of cases has dramatically increased over the last 10 years of people getting into TB programs, now the question becomes, how can we optimize those treatment outcomes for people? And really there's a couple of important benefits. One is the benefit for the patient themselves. So people who are started on treatment, if they don't get proper treatment completion, then they can have poor outcomes such as death or chronic complications of TB, but also for their communities, they can spread TB, and there's also the risk of acquired drug resistance. So all of those are reasons why effective TB treatment is important. Now, there are several factors why people might not take all of their TB treatment, and some of them are listed there. So one of which is they may find that the treatment is not effective, and so the disease persists, and that may then contribute to the patient dropping out from the program because they don't feel that the treatment's working. As we know, for TB treatment, particularly for drug-resistant TB, but also for standard first-line TB treatment, that there's a considerable risk of toxicity, particularly for patients maybe who don't have close monitoring by programs, and so that can lead to discontinuation of therapy. A frequent problem that's been identified in the literature through qualitative and quantitative research is that patients often are not engaged in the programs throughout the whole of treatment, and particularly towards the end of treatment when they feel better, they may drop out from treatment. And underpinning all this is that patients may actually not take the treatment that they're given. And we often blame the patients for this, but in fact, as I'll discuss in a second, it's very much about the system failing the patient and not being able to deliver the appropriate quality of care that the patients require to get them through that treatment journey. Now, I mentioned drug-resistant TB, particularly for drug-resistant TB, this issue of poor treatment outcomes is a really major concern. You can see in the figure on the right of the screen there that over the last 7 or 8 years, that we really have only made limited progress in improving outcomes for people with drug-resistant TB. That 57% of people have treatment success, but that still means that over 40% of people are still not getting the treatment outcomes that they need. And that's not because we lack effective medications. If you look at the MDR program in a country like Australia, we would have pretty much equivalent outcomes for our MDR patients and our non-MDR patients. So there's got to be something more than just the drugs that we're giving people to explain it. And so all of this is to say that treatment adherence is a really important priority. And it's been one which historically has had a very sort of, top-down approach. The DOT, so directly observed therapy paradigm, which has been a part of the WHO's strategy in the 90s and the 2000s, was that patients would be observed to take their treatment, and therefore they would take their treatment, and therefore they would be cured. As well as being top-down, it failed to understand or recognise many of the complexities around the reasons why patients may not complete treatment. And they may include psychosocial factors. We've done some work, including with Lisa Redwood in Vietnam, looking at stigma, and showed that drug-resistant TB particularly is is highly stigmatized. Depression and mental illness and alcohol and substance abuse is pretty common, as we've heard from Carmel this morning. There are structural factors that can interrupt treatment support, and it can be as simple as costing a lot of money to get to the clinic to be able to actually access the treatment, or it could be difficulty getting time off work to go and visit the healthcare system. And it can be the healthcare system is not set up to be able to support patients. And so in reaction to the sort of fairly top-down approach of the directly observed therapy paradigm, which is now being moved away from in many countries due to a lack of clear evidence of effectiveness, and you can look at the Cochrane review there if you don't believe me. The WHO and the NTB strategy now really emphasises patient-centered care. And a part of that is to think about how can we sort of flip the dynamic around how we treat patients to start with the patient first and say the patient is not a problem that we need to manage and control, but a patient is somebody we need to work with and support in order to go and improve their treatment outcomes. And at the same time as this shift in paradigm, there's also been a shift in technology, and the WHO, as well as other international organisations, have really been trying to leverage the advantages of smartphone technology and access to the internet to support healthcare. And so you see a reference there to the NTB digital strategy, which I'd encourage you to read. The question, though, is how can we tap into that? How can we use technology in a way that's going to be patient-centered and try and bring those objectives together of patients' needs as well as program needs to support patients to get good treatment outcomes. It's really remarkable. The field has changed in the last decade because there's just been this explosion of access to smartphones. You can see here that back in 2012, there was about 1 billion smartphone users around the world. Now that's 4.3 billion smartphone users. So it's just an incredible change, and it's very likely to continue. And what that means is that every country should be able to provide in a patient's pocket a device that can support them get access to healthcare providers throughout the day, and can provide them information and different things that were not possible. Even, I know in Vietnam, the Seom drivers sitting on the side of the street waiting for their $2 ride, or they now use a thing called Grab, which I guess is using their smartphones. They all have smartphones. The way that they communicate, even if they've got very low incomes, is smartphones. And so we should be using this increasingly. And so if we look at the two studies I was talking about, I'm going to talk about one which is completed and then one which we've got underway at the moment in Vietnam to try and harness this technology. The first is a study called V.2, which was a randomised controlled trial supported by the Australian Respiratory Council and implemented in partnership with the Vietnam National TB Program. By way of background for this study, there was a randomised trial published in PLOS Medicine about 5 years ago, which used a device called a MERM, which is a medication event reminder monitor. It's basically a box, I'll show you a picture in a second, that beeps when you have to take the medication, and it records when you open the box, and it sends the signal to a mobile phone tower that you can then download, and then you can report individually for each patient when they've opened the box, and you can use that to quantify their adherence. Now, the study in China found that there was no significant benefit from text messaging to support patients, but there was a substantial reduction, about a 40% reduction in poor adherence with using these medication monitors. And that was a large cluster randomized trial. So what we essentially sought to do was to say, well, does this work in Vietnam? In Vietnam, and you'll see some talks about Vietnam, I won't go into the epidemiology in detail, but just to say it's one of the high burden countries for both TB and MDR TB, and there's an estimated 174,000 people developing TB each year. We worked in a province called Thanh Hoa, which is a northern industrial base just outside of Hanoi, which has got urban and rural populations, and you can see the prominent building in the middle of the town, which is a hotel, which has a great view. I don't know how that got through the development application process, though. Anyway, so the aim of the study was to evaluate the feasibility and effectiveness of digital adherence support amongst outpatients with newly diagnosed smear-positive pulmonary TB. And individuals were randomized either to a control arm where they had the box but it didn't beep and they didn't have any action taken when they didn't take their treatment, and then an arm where the box was recorded, and we printed out a summary of the adherence for the healthcare workers, and the healthcare workers would use that information to go and counsel the patients to try and improve their adherence. And so basically the intervention was to use the full functionality of the box. We included people who had at least 4 months left of their treatment and who were aged 15 and above, and we excluded people who had, in this case, multi-drug resistant TB. This is a picture of the box. It's actually relatively old technology now that uses the 2G smartphone network, and it has a battery which can last for sort of 3 months to 6 months. And each day there's a sensor in the lid which opens up and it sends a signal across to the mobile phone network. And you can also tell on the thing you download whether it's running out of batteries, and so you can replace the battery when they come into the clinic the next visit. And so the data goes to the server, and then from there to the healthcare worker. The primary outcome was the proportion of patients who had missed less than 3 out of 15 doses, i.e. they took most of their doses. And the secondary outcome was a slightly lower threshold of patients having taken 7 out of their 15 doses, missed 7 out of their 15 doses. And so I won't go too much into the methods, but I'm happy to answer questions about it. Essentially, the discussions were a part of the conversation when patients went in for their routine monthly follow-ups in the clinic. And so this is the population. We recruited 250 people, and you can see most of them are men. The majority had at least secondary school education, and around 40% of them were unemployed or retired. And you can see that previously, only 30% had been smartphone users. This is a picture of one of the doctors in the clinic with the Wise Pill box on the table. And I'll just skip through here to show the results. And it shows you here that the orange line is intervention. And so you want to as close to 100% as possible. And the blue line is control. So you can see here that it looks like throughout the treatment period that there were higher rates of use of the treatment each day in the intervention compared to the control. When we looked at a slightly lower cut point of doses, it wasn't quite as clear at the start, but even after 3 months, it seems like that there's a difference. And so when we actually look at the primary effectiveness outcome, which is the top row there, you'll see that there was about a 30% reduction in poor outcomes in the intervention group compared to the control group. That is 35% of people and 25% in the intervention group had at least 3 out of 15 doses missed. The statistics are a little bit complicated, but I won't have time to go into them, but I refer you to Kavi Velen, who has been doing this excellent analysis. And also we found that when we used different cut points, there was still an effect. So this is using an odds ratio, that the effect was to increase by 2.6 times the proportion of people who had taken at least 24 out of 30 doses. So in other words, it did appear to be associated with increased adherence. There were some limitations. This was an open label study. It was only with drug susceptible TB, and it was only in one site in Vietnam. But it does provide validation for the evidence of the study in China. And I think it shows that this type of technology could be useful. There was a qualitative study, however, which was not as entirely glowing. So this was done by Sarah Bernays and Shannon McKinn and Dorothy Drabarek. And they've published their findings, and I welcome you to read them. Essentially, they found that many patients weren't actually using the devices as they were intended because it was still quite doctor-centered. The doctor would set the alarm at 9 o'clock, and the patients felt they had to take it at 9 o'clock, even if they left for work at 7 o'clock. And so you had this sort of effect where they would open the box at 7 o'clock, take the tablets, and then they would open it again at 9 o'clock to try and meet the needs of the program. So we did try over time to adjust it to make it more patient-centered so we could set the time of the alarm based upon when the patient wanted it to be open. And there were limitations that they couldn't take it to work. It was a bit stigmatizing to have this big, white box with you in your backpack every day. So there are technologies with HIV treatment where there's much smaller devices. So I think there's room to move there in the TB space. Of course, we have a lot of tablets in our TB regimen, so it makes it hard to reduce the size. So the conclusion, I think, is that this technology moves us further in the direction of patient-centered care, but I think we still have some way to go, and I think qualitative and quantitative methods have a role to play in helping to optimize these therapies. And just in the remaining 2 minutes, I'm just going to talk to you about another digital health study which is ongoing in Vietnam, for which we don't yet have results, the VSmart Study. All good studies need a logo. I note the Pearl logo is excellent as well. So the VSmart Study is a study which is funded jointly by the NHMRC and by NAFOSTED, which is the Vietnam Peak Scientific Funding Agency. And it aims to use smartphone technology to support treatment adherence for multi-drug resistant TB. And so we are using an app which we've developed called Baxi Ming, which means smart doctor. And we're comparing the use of that app to support patients with MDR-TB to people who don't have the smartphone. And you can see the secondary outcomes there relate to the time to sputum conversion and the proportion who report adverse events. And actually, we want more people to report adverse events. That's actually a good outcome because underreporting is a common problem. So this is being conducted in 7 provinces in Vietnam. It's an open label study, and we're enrolling 902 participants approximately. And there was a lengthy process of app development. I can talk to you over coffee at morning tea about the agony of app development, but nevertheless, it's not as easy as it looks, but I think we have a nice app at the end of the day. And it's been pilot tested in Vietnam with doctors and with patients. Basically, the patients have an interface where they every day enter how they feel. And if they feel unwell, which is indicated by like a frowny face, then they get asked more questions. And then they depending on the symptoms, they may get encouraged to call the doctor or be told to continue taking their treatment. And then the doctor will have an app, and on their app, they get told which patients entered that they had an adverse event or they were unhappy, and then the doctor will be prompted to follow up with the patient. And so it's a two-way communication process. And there's also a website, an app website, where you can look and see what the overall usage of data is of the devices are through Google Play and through Apple Store. And so basically people are enrolled, they take their standard treatment with this support, and then after 12 months we collect information about the outcomes and the costs, and then after 24 months we look at their overall treatment outcome of drug-resistant TB. And in Vietnam, remember, about 30% of people have unsuccessful treatment outcomes from MDR-TB. So quite a lot of the people who are on treatment which should be effective are not completing their treatment. So this is a very exciting study. We've been recruiting for about 6 months, and we've recruited, I'll show the numbers in a second, I think about 130 people. And we've got a number of sub-studies that we've got underway. We're working with Jan Willem to look at pharmacokinetics, and we're doing some qualitative research and looking to try and use artificial intelligence to try and streamline that process of communicating with patients who have toxicity. And so this is going to be an ongoing trial. We expect the results in about 2 years' time. And you can see here, it's the summary of the recruitment so far. So about 16% have been recruited. So I'd like to acknowledge the National TB Program. All of this work is not possible without Professor Nhum, who's our key in-country partner, and also Dr. Nguyen Binh Hoa from the National TB Program. Dr. Kavi Vellen's been working on both of these projects. He's not able to join us because he's in South Africa right now, but I'd like to acknowledge his enormous work on both of these, particularly on the establishment of the VSmart project, and also to thank Dr. Tuang and Ter, who's our project leader in Vietnam, for all the work that they've done, and our funders. Thank you.
Okay, we're a little bit behind time, but is there any one question that people would like to ask? So this app, can we look at it at morning tea? Sure. So if you cluster around Greg's phone at morning tea, you can look at the app, and you need to record yourself with a smiling face. Is that correct? Okay, well, Michaela, ask a quick question.
Just a very practical question, Greg. Has it been set up for translation ease for other contexts?
Yes.
And you've trialled it in places other than Vietnam?
Only in Australia and Vietnam. So it's in English and Vietnamese at the moment. It would be possible to translate it into other languages. Yeah.
Okay. So thanks very much. And we trust that Tuan's online, and we thank all of our collaborators in Vietnam very much.